Hello and welcome to Pulse, your podcast delving into all things health, innovation, digital and data. Proudly brought to you by Pulse IT News. I'm your host, Louise Shaper.
And I'm your other host, Dr. George Margellis.
George, how's the last couple of weeks been for you? What have you been up to?
Well, the last fortnight hasn't probably been as much fun as you've had, Louise. I'm looking forward to hearing about that, but it has been pretty busy. We're still combing through the new Aged Care Act here and its technology connotations. Our good friend, Faith Lavaris, our favourite First Secretary, gave another one of her very informative tech talks, and we learnt more about what to expect on July 1st next year. And there have also been some changes in the roles of the Department of Health and Aged Care. So the introduction of the new Chief Digital Information Officer role, which Faye is currently acting in, suggests that there's actually some things happening around digital over there. The rest of the aged care sector is still worried greatly around what this new reforms mean. And we've been looking at how technology plays a role there, but it is a major reform on our way. So anyone over the age of 65, get ready for some major changes in your life. The other fun thing I did was I attended virtually the Hong Kong Gerontech and Innovation Expo Summit, which included a number of Australian presentations. It was quite a good event. They did it all online, and we actually had a couple of Australian presenters, including some Canberra stuff. So we're starting to see lots of more interesting interaction globally for Australia.
Who hosts that event?
It's run by the Social Services Group in Hong Kong. I met up with them when I was there earlier this year for their health tech event. It's interesting because, again, it's very Hong Kong focused, but they had people from Singapore, from Japan, and even from mainland China talking about some of the experiences there. And there's some interesting opportunities. So we're looking at how we're going to interact better within the region. And I think next week when you're at Health, you'll probably meet some of my colleagues who have been working on the healthy aging ecosystem, and they're bringing the rest of the country into it. The other fun thing I've been doing is keeping up on my reading, as I love to do. But I do note, and I thought this is something we should keep in mind for our discussion, that two of this year's Nobel Prizes, Nobel Prize in Physics and in Chemistry, both went to people around AI. So I did keep an eye on what was happening there. And part of that included a New England Journal of Medicine webinar on patient-based AI, which I attended. Unfortunately, it was 3 a.m. in the morning here. So, yeah.
I registered for that, George. And I was hoping they would send us the video link afterwards.
They did promise me afterwards, because I'm not quite sure how much I did take in at 3 o'clock in the morning, but it was an interesting event.
Oh, cool. Very good.
And the other thing, of course, things have been a bit slower down here, Louise, because without you in the country, digital health energy seems to have dissipated. We haven't got Louise here, so we're looking forward to getting you back to get that digital health energy up and running again.
Oh, cool. I'm looking forward to coming back.
How's your fortnight been? You must have been having a fun time.
I have been traveling. I've been hitting the road for the last week and a bit, quite literally. So Ryan and I flew into Los Angeles just over a week ago, drove 2 days to Albuquerque, spent about 4 or 5 days staying at this awesome Airbnb with Ryan's family. Like all the family flew in. He grew up in Albuquerque. So we got to see the car wash where Walter White laundered money in Breaking Bad.
Wow.
And it was an interesting trip because we got to see that, the air balloons. They have this hot air balloon festival, which was really cool. And then I also got to see where my partner grew up, which was really nice, and spend time with family. So we did that. And then we drove for another 2 days and came back to California. And I'm currently in San Diego. So Chris Longhurst and his lovely wife and kids have put us up. So I'm still here in San Diego staying at the Longhurst and have had a really wonderful time.
Sounds fantastic. In your long drive, did a roadrunner come next to you and go beep, beep and get you out of the way?
Yes, well, almost. I was like, what is that? And there's this relatively small bird, sort of like a big chicken size-wise, doesn't look like a chicken, but size-wise. Everyone's like, oh, that's a roadrunner. And I was very excited. And then I saw another roadrunner when we drove to the house that he grew up in. And there was a roadrunner in the garden. So I got to take a picture of that. So that was very exciting and a lot of, meet me.
But what about Wile E. Coyote? Was he floating around as well?
Did not see any coyotes. Have heard a few singing at nighttime, but have not run into them. But a couple of things that actually in San Diego yesterday, I went to a breathing class, and then, it's like an hour-long class where you basically hyperoxygenate. So you breathe really quickly and hold your breath. And Anyway, it was a really interesting thing to try. So I did that yesterday. And then we did a cold plunge. And anyone who knows me knows I hate being cold. Like, it's the only thing that gets me grumpy is being cold. And I got into this water because I was like, oh, I'm here. I'll give it a go. And your body freaks out. And it said on the wall that it was 40 degrees Fahrenheit, but I have no idea how cold that is. So anyway, jumped in. I was like, Jesus, it's really cold. Anyway, so breathe through it, try not to panic. And then I got out, and the guy who was, it's very American, like it's all high-fiving. Well done, you did it. And he goes, how long do you think you were in there for? And I said, oh, I don't know, like 1 or 2 minutes. I was in there for 5 minutes. And
Wow.
I'm very proud of myself. And then I went back and did it again. And when I got home, I Googled what the temperature conversion is. So for those non-American listeners, 40 degrees Fahrenheit is 4.5 degrees Celsius.
Ouch.
Really cold.
Ouch.
Anyway, yeah, it was a cool experience.
Only in America, right? Only in America.
Yes, breathing classes. I don't think we'll have them in Melbourne for a while. It's been very good. I suppose we should get to our first hot topic. And George, we've got a lot of health data and health data releases to talk about today. First up is a study that was published in the Australian and New Zealand Journal of Public Health, which mapped public health funding from both federal and state and territory governments in Australia. The study found that Australia spends only $140 per person annually on prevention. That figure is shockingly low. It represents 1.6% of healthcare spending. In the UK, they spend about 4% on prevention, and Canada, they spend 6%. In an accompanying article, which was actually written by outgoing AMA President Steve Robson, he wrote a piece entitled, "The solution to the health crisis is simple. Don't get sick." He stated an opinion, George, that you and I do agree with. He said, if our health system is to be sustainable in the long term, then the only option is to flip our thinking from providing care for established disease to preventing illness in the first place. Now, what struck me in both the published research and Steve's piece is that there was zero mention of health innovation and digital health being able to be deployed to help turn healthcare around from a reactive, acute focus to a proactive prevention healthspan focus. Now, after 30 years of Australian academic research and what we now refer to as a digital health industry, I think we still clearly have a long way to go to make this industry mainstream thinking across the health sector. I would have thought those topics would have been in these articles, but they weren't. What are your thoughts, George?
Well, looking at the good old prevention is better than cure debate and has been popping up for many, many years. I mean, it's great to see it's still going on. And to my perception, the best form of preventative health really is health literacy. So unless we can actually educate the population about the necessity for things like health screening and health preventative measures, and that really requires us to integrate with education and with social services, because from what I understand, the health literacy training or education is not part of a public health budget. It's all part of the education budget. So I guess we need to bring everyone to the table. But I do note there was a quote within that original article. The funding of public health in Australia is regarded as inadequate, siloed, sporadic, short-term and piecemeal. You could replace public health with basically any other type of healthcare system model in Australia as well, and it would fit into that really well. So it really is a generic problem. A couple of weeks ago, I went to a very interesting session. Professor Sean Larkin, he's a professor in health policy and finance in the University of Sydney within the School of Public Health. But you may recognise the name. He used to be the managing director of one of the largest private healthcare funds in Australia before he's gone into academia. And he had some really interesting discussion around the challenges around preventative health in Australia. So, private health insurers are always trying to drive that model of preventative health. They do it for the obvious reason that if they can prevent an expensive hospital admission, it's to their benefit. So, not to say they're doing it because they're wonderful human beings, but they see a business model around it. And he talked about some of the challenges he faced back in his days in private healthcare where they try to introduce some of these systems. This is a multifaceted problem. But if you look at how slow the progress has been over the last few decades, utilizing that computer in everyone's pocket that we all have for good rather than just using it to TikTok the Kardashians is probably a better use of technology than what we currently do. But, we do have to worry about those equity issues. There are people out there who don't have the latest and greatest computer in their pocket. So we need to make sure they have access to these sort of things. And we need to make sure that the marketing, as they so call it on Facebook for healthcare, is actually evidence-based and not just another way of getting into people's pockets.
We talk a lot on the pod about the business of healthcare, what we finance, where we choose to spend the money, and how you're financially compensated for the work that you do in healthcare. And, both of these things and the articles I was reading around it, it really is just business as usual. The solutions are always about, well, we need to spend more money rather than looking more critically at what's going to be realistic and how do we create this paradigm shift in health consumer behavior. Digital health isn't going to be a panacea, but there should be ways that we can use technology to change behaviour. I looked at how many people get admitted to Australian hospitals over the course of a year for conditions that actually could have been prevented. By the time this episode of the Pulse Pod finishes up, 80 Australians will be admitted to hospital for conditions that could have been prevented just in 1 hour. It's a huge number, and yet we're still not changing the way we fund healthcare.
Yep, it's been an ongoing discussion, and we've seen books about disruptive innovation and different types of innovation in healthcare, but the reality is the basic models of healthcare haven't changed in many decades that I've been involved in healthcare, and we're still having those discussions.
Yeah, I really hope it changes in my lifetime. I'd like to think we were smarter and worked a few things out differently. So anyway, that'll be a topic we revisit.
Absolutely.
In our next hot topic, which is also related, longevity and healthspan. We know that they are the latest Silicon Valley health darlings. There's a plethora of new startups around the world promising to collect and measure key data points and give individuals information to help them extend their health span, which is, if you haven't heard that term before, George and I would let you know that it's basically just the portion of life that you spend in good health rather than living to a ripe old age and having high longevity, but those last years you're not in such good health. So anyway, there's all these startups around that are promising to extend health span. And there's also a heap of biotech companies backed by venture capital to uncover the secrets of longevity. Now, George, this is a topic of interest to us both. We've read the books, you way more than I have. I've read some of the books. We follow the research, we've seen the pitch deck and the promises. And full disclosure, one of the companies I'm working with at the moment has a health span focus. But despite all of this interest and this money that's being poured into them as well, a new study, which was published in Nature Aging, suggests that wealthy nations such as ours may have actually reached a life expectancy limit. Now, it's always better news for women than men when it comes to these things, but still, the study predicted only 5.1% of women and 1.8% of men are expected to survive to 100. If we want to live longer and extend our health span past 100, we need to cure most causes of death, is what this article said. But, is that possible? The data shows that chronic disease causes 75% of all deaths globally, and it's on the increase. But many of these conditions are caused by lifestyle and behaviour, relevant to our first hot topic. What are your thoughts here, George?
I have to admit that Nature Aging is actually one of my favourite publications. It really has some really interesting articles in it, and they are sort of really well researched. So kudos to the people who wrote the article. And this article really has sprung up a lot of interest in the aging space over the last couple of weeks. And it's because we've had lots of discussions around exponential change. Now, I'm old enough to remember doing 4-unit maths when I was back at school. And there are different types of curves, and sometimes curves plateau out. And whilst a lot of the people who speak about exponential growth and change in healthcare have sort of pointed to this model of us continuously going forward, the reality is that human physiology and biology is pretty complex, and there may actually be some physical limits to what we can do. The original idea about longevity escape velocity was something coined by Aubrey de Grey back in 2004. And Ray Kurzweil's book, who I noted last podcast, sort of goes on about it. But the reality is we are still challenged to fully understand how the human ecosystem works, how physiology and anatomy works. And as with this year's Nobel Prize in Medicine went into the study of microRNA, which is an amazing topic around how very small particles of RNA actually influence how our genes are expressed, which is something which, when I was at med school, didn't even exist. So I think that those innovative changes and understanding, but to people like me who are getting older, the concept of extra couple of few years here and there is well respected. But I know there was another very interesting article this week which came out, which debunked the old blue zones of longevity model. I don't know if you saw this model.
No, I didn't. What did that say?
So that was interesting. So when they sort of started looking at these blue zones where they said that people live to be 100 plus, and the island of Icaria, one of the Greek islands, is supposed to have the highest incidence of 100-year-old plus men in the world. When they did a little bit more scratching of the surface, they discovered that what these blue zones were particularly good at was pension fraud. What they managed to do. So there were a lot of people who were listed as living over 100 who were actually long dead and buried, but they were continuing to receive their pension. So it would appear that my Greek compatriots in Icaria may not have been as healthy as what we thought they were, but they were very financially adept at getting credit for it. So again, so we need to look at, when we measure these things, make sure we do it properly. I think that's really important.
I love that. Okay. That's really funny. I love the ingeniousness of that approach. The other things I was going to say, George, is I'm just thinking about the role of AI, because every episode we have to talk about AI in some level. And there was a recent study which looked at diagnostic accuracy. We'll put a link to this one in the show notes, because the study showed that not only was AI better at diagnosing illness than doctors were, but when they gave doctors, they had a control group. So they had, doctors diagnosing, then they had doctors diagnosing with the help of AI. So they were able to use these generative models and LLMs, and then they just had AI on its own. And when the doctors were given AI to use to help them as a diagnostic aid, they basically didn't really change their diagnostic accuracy. It only changed by a couple of percent. So AI beat doctors, the AI, 88% accuracy. But even when doctors had access to AI, it only went from 73% to 77%. Now, this was a small study, only 50 clinicians, but considering the importance of diagnostic accuracy, I'm wondering the role of AI and what we will see there in terms of its role in diagnostic accuracy, but also that relationship between doctors and AI and that collaboration in clinical practice.
We've seen a lot of studies around the diagnostic accuracy of AI. We've seen how they can better read x-rays and give us more information. One of the real questions we need to start asking ourselves is diagnostic accuracy really the benefit we're looking for? We saw this in screening, and so we really need to think about the outcomes. So we need to think about AI as a tool, but start assessing its role in improving outcomes. And I think that's where the next level of AI research needs to be. Do people live longer, live better as a result of the AI interaction, or does it just improve our documentation, which is a nice to have, but hey, that's not really what we're aiming for in healthcare care.
No, but of course, for some people, that diagnostic accuracy is a huge difference, because it can be the difference between life or death, as well as all the frustration ongoing. We know people like Regina Holiday. Unfortunately, her husband ended up dying. Story starts, it was just a sore shoulder, I think, from memory, similar to e-patient Dave. But because it took so long to get an accurate diagnosis, by the time it was properly diagnosed, it was too late for him. So I think that's where the speed and accuracy can really mean a big difference for people.
And we have seen some amazing results in prenatal early childhood diagnosis, where they've picked up things that are so rare that the normal doctor just has never been exposed to them. I think the key thing here, of course, is educating our clinical workforce to better use AI. And we need to have our medical and clinical schools have departments of AI. And we had a discussion on one of our earlier podcasts about, do we need a chief AI officer? And I think it's becoming a more and more important role.
Yeah, I'd agree with that. Absolutely. Our next hot topic is the Commonwealth Fund. Now, their latest report compares the performance of health systems in 10 countries across 5 domains of access to care, care processes, administrative efficiency, equity, and health outcomes. Now, the aim of the report is actually to glean insights for US improvement. The Commonwealth Fund, despite its name, it's not a part of the British Commonwealth. It is its own organisation. It's a United States think tank. But of the 10 countries, the report revealed they're basically wasn't a hell of a lot of difference in the performance amongst 9 countries, but the US was a clear outlier. The US fared so badly that it actually attracted a damning headline while everyone was reporting it this way. The US continues to be in a class by itself in the underperformance of its healthcare sector. All other countries seem to have found a way to meet their residents' most basic healthcare needs, including universal coverage, but not the US. Now, we will put a link to the show notes for this study, because it's really interesting when you dig it down into the data, because the top 3 countries overall were Australia actually came in first, which I was surprised about, but yay, go us. Australia came in first, Netherlands second, and then the United Kingdom. But George, Australia might have come in first overall, but on one dimension, which is access to care, out of 10 countries, we came in ninth. So I was interested in how does that really reconcile? Because surely access to care is pretty much the starting point to getting care. And the only one worse than that is America. We're the worst.
Yep. I have to admit, I do love the Commonwealth Fund reports. It's always been a way for me to rib my US colleagues about how bad they are and how good they are. And we always do manage to beat them. And Australia did come in first, which is something to be proud of. However, the overall score is a bit of a lagging measure. It's very concerning that we did so poorly in access and care coordination care, because you would expect those things to be leading indicators of poorer outcomes in the future. So this ties in pretty well with our discussion earlier about public health. We do have things like Health Direct in Australia, which do interesting work in delivering virtual. But let's be honest, in reality, the average Joe Blow on the street doesn't know about that. I mean, those of us who live and breathe digital health may be aware of it, but the general population isn't that aware of it. And if they do, they rarely use it and only use it as a triaging service. And then we've seen, and we've had this discussion again on our podcast about the burden of primary care. I've described earlier how in my days, the people graduating from medical school went into general practice. In my son's days, only one of his many colleagues that he knows at med school went into general practice. There's no drive there. And part of that's just driven out of the fact that it's not seen to be an admirable profession and is poorly reimbursed. And we've seen it from the other side. I've visited a couple of GPs with the family recently, and the out-of-pocket costs for a GP, yet alone a specialist in Australia, are really starting to rise. And that in itself is something which makes it harder to access the healthcare system. So Medicare is a health insurance system, but it hasn't been in sync with what's being charged. Is that Medicare's fault? Is that the clinician's fault? We can have that discussion, but the idea of universal healthcare sort of has lost its way, and we're now back to a two-tier system that if you can afford to pay for primary care, you do it. Otherwise, you line up at the emergency department, you line up at the urgent care clinic, and you hope to get whatever you have wrong at that time treated. But again, they're not part of the continuity care program. So there's some disparities in our system that need to be worked on. And I think the fact that we came 9th out of 10 in access to care should be very alarming for us. Then that it does suggest that maybe next time the Americans will beat us, and that will be terrible if they get beaten by the Americans in the Commonwealth Fund.
Yes, Mark Butler, if you're listening, that cannot happen, Minister. But also, I thought the other thing, if we looked at the digital and innovation angle, where Australia could easily make some gains. So rural care, we were the worst ranked of the 10 countries. So that even the US beat us in terms of equity in rural areas. And then the other one that we ranked pretty poorly and we got in 8th was around care coordination. So basically that 8th reflects that, there is a lack of coordination within the system, raising up their accessibility to care. Digital has a huge role to play in there. Things like, I don't know why we're rolling back telehealth. It just makes no sense.
Absolutely. Those of us old enough remember Michael Georgiev's work 15 years ago on the care coordination platform, which was world leading and shunned brightly for a while and then sort of got lost in private equity. I mean, we've had solutions here in Australia, but we just never think about our healthcare system as a whole. We think about it as that article recently stated, inadequate, siloed, sporadic, short-term and piecemeal. I think that has to be the quote of the week for us, in that our whole healthcare system is beleaguered by that challenge.
Yeah, it absolutely is. All right. Well, lots of work to do, all of you pulse potties out there trying to influence the healthcare system and making key decisions. We can improve on those numbers before the next Commonwealth Fund report comes out.
Absolutely.
And in our final hot topic, George, we are predicting a rise in triage services enabled by AI and even AI-led, which will replace the need for human triage services in some settings. This came about. A GP practice in London has reported deploying an autonomous AI to do triage, and it has substantially reduced patient waiting times to get an appointment. Now, this isn't from a peer review. It's what they're saying their experience has been, and they've seen some amazing data. So patient waiting times reduced by 73%. So 11 days having to wait for an appointment down down to 3 days. The practice said that they had 47% fewer phone calls during peak hours, 70% fewer patients needed a repeat appointment, and 91% of appointments were automatically allocated without any staff or clinical intervention at all. And there was also another data point they reported that GPs were now spending 50% more time with each patient. Now, I have been not just traveling around seeing families and seeing the sites, I've been doing a lot of work while I've been in the US, and I've been talking to healthcare leaders here, and they are telling me that they are investigating similar models for this triage enabled by AI because they expect similar results.
Yeah, look, the AI chatbot is a game changer, and using it as a first line of triage, I think, is a great idea. But you have to make sure we deliver it in an effective way. The last thing I want is calling a number and saying, if your head hurts, press 1, your chest, press 2, your stomach, press 3 conversation. I mean, I really don't want that to be my experience. User design is critical. Equitable access to the tool is also essential. So we need to sort of think about how we design these tools to make them useful for those who are using it. And speech recognition may well be the key. It may well be that we've reached that point in our technological journey that we can have these speech recognition as a tool. But this idea, and it's been fairly popular recently, the digital front door. What is the digital front door that we utilize, and how does AI take a role there in that? And I think that's really going to be an area of a very exciting development. But again, we need to think about what are the resulting outcomes, not just the efficiency gain. So does it actually affect the outcome? And this concept of clinical utility, which has been around for a while, but we need to re-explore that. Sure, it may remove a couple of staff salaries in the system, but if the health outcomes aren't as good or better, then is it something we should be doing? But judging by the mere fact that we talked about earlier about access to care, if we can speed up access to care through these sort of tools and develop them in a realistic way, make sure we put the guidelines and boundaries around them, and continue to develop the evidence base. We often talk about here about how important research is. I think this is going to be a game changer. It'll enable us to access healthcare better. And if we can get this right in Australia, we may go 1, 1, 1, 1, 1 in the Commonwealth Fund. Get the whole way.
That's it. That's what we need to do. And yeah, I think this is really interesting, but also scary, depending on which way you look at it. The potential, as you were saying, to transform patient flow, that using these tools, especially if they're autonomous, what our first point of call is for healthcare before we go anywhere else. That'll be really interesting. One of the healthcare leaders over here I was talking to the other day, she was saying that their call center, like where you ring up and go, oh, I'm not feeling well, they employ hundreds of people. So it's not just necessarily a few people lose their jobs. We could be talking about significant numbers of people doing those triage services. But, some of those triage services, those call centers are staffed by nurses. So they could be more effectively deployed in the system, actually delivering care rather than just triaging. It'll be really interesting to see how quickly these AI triage services take off and what the data is going to show us about their effectiveness. Because if they do work really well, like this one GP clinic found in the UK, it could mean displacement for workers. But then if those workers can be better placed, and also if the triage service is better, because like we were saying earlier with the AI diagnostic accuracy, maybe it creates more capacity in the system, more people to deliver care to less people needing the care.
Absolutely. And look, job displacement for technology has been a topic of discussion since the days of the Industrial Revolution. So yes, some jobs will be replaced and people will need to reskill, and there'll be some cultural and society changes associated with it. But the reality is AI is here to stay. I think we're no longer expecting as many AI winters as we've had in the past. And we need to play a much larger role in how it's good. Enrique Carrera highlighted that maybe we should be starting with these back of house things rather than trying to put it straight away in front of house, and improving efficiencies in the back of house by making sure that the right people get access to the right care at the right time provides us with a more efficient healthcare system. Personally, I'm not a big objector to more money being spent in healthcare because, again, it's money which is spent within the economy. And yes, you may spend more on local healthcare, but it gets circulated within the economy, and that's a whole economic discussion to be had. But we do know that funds are tight. Governments all have their own restraints around funding. So using this to make the system more efficient has benefit, but we just need to make sure we measure all the benefits and look out for those unintended consequences which sometimes pop up or across those as we go forward.
Yeah, absolutely. Because yes, patient safety always needs to be paramount. Well, I think it's time for a brief break. After this brief break, we will be back with our special guest of Pulse, Rachel Dunscombe, freshly back from addressing the United Nations in New York. Today, we have the pleasure of having Rachel Dunscombe join us in the PulsePod studio. Hailing from somewhere between Manchester and Liverpool, Rachel is a renowned leader in the health tech space. She's had some pretty impressive roles, including the inaugural CEO of the NHS Digital Academy, Professor at Imperial College London, Advisor to the UK government on AI 6 years ago, and CIO for various health services. Rachel is a key figure in advancing digital health systems globally, working with governments all over the world to advance their digital health agendas. Rachel recently spoke at the United Nations General Assembly in New York on the topic of leveraging AI for global healthcare delivery, where she shared her insights on the role of data quality in driving AI in healthcare. This discussion aligns with her ongoing role as CEO of OpenEHR International and Director at the European Connected Health Alliance. Welcome to the PulsePod studio, Rachel.
Thank you for having me.
And it's great to have you on board, Rachel, especially now since we're on 3 different continents doing this call.
We pulled it off. I'm very impressed with us. Well done, guys. Okay, well, we'll get started. Rachel, for the Pulse Poddies who don't know OpenEHR well, tell us more about the organisation, what it does, and what do you do as the international CEO of the organisation?
So OpenEHR is something I discovered when I was a CIO, and I just found my data was completely feral. Concepts were recorded in hundreds of different ways throughout the organization. And OpenEHR is basically a community of individuals, clinically driven, who create optimal data models that are engineered really well for healthcare. So it's a vendor neutral information model. We're completely not for profit, really frugal, working with 114 different countries. We're seeing all sorts of countries adopt this. So, for instance, Greece, for its integrated record, has gone with it. The London integrated record uses this. We've got stage 4 cancer trials in America. We've got all sorts across those 114 countries. But the aim is to stop vendor lock-in. And the aim is to enable great data for the likes of AI, direct care, and the longitudinal record. We're citizen-centric. We're looking to create the data layer for the next generation of healthcare. That said, OpenEHR has been running 22 years. So, Professor David Ingram started it in London in UCL with a whole bunch of Australians 22 years ago. So this is something that's been running for a long time and has been used quietly. But we're getting to this point now with AI where we need great data. So I agreed to kind of take on the CEO role because it's really important to me that we do get that data right.
Yeah. And how many volunteers do you work with, Rachel? So many, isn't there?
There are thousands. We've got nearly 4,000 clinicians globally. So it's a big community, and I'm very grateful to everyone that contributes.
Awesome.
There are a couple of Australians who have been involved. Sam Hurd and Heather Leslie for many years have been actively involved.
Yeah, absolutely. So it's truly international. It's every continent. And it's really lovely, actually, to see this because in healthcare, we've worked at a country level before. But now we're seeing other standards bodies like HL7, Odyssey, SNOMED, who are working internationally, and we're working side by side with them. So it's really good to see all the standards bodies moving forward together.
And the interesting thing, of course, is that it looks at the data, not the EHR system itself. As we'll be discussing later, obviously with AI, data is the key. So before we jump into the substance, tell us first about your invitation to address the United Nations. How did that come about? I understand the ECHA Alliance had a role to play. Being over there with all those key worldwide figures must have been a very exciting time.
Yeah, so it actually started about 3 years ago. And the Digital Health Society, which is the sister organization of the ECHA Alliance, asked me to chair a group called the AI Club, which brought in policymakers, industry, all sorts of people to look at the state of AI and make some recommendations. And a year ago, I virtually presented to the UN, and we talked about lifecycle management, we talked about data, we talked about skills, and I did a session that sort of summarized all of our findings and where we were. On the basis of that, I actually got invited physically this year, which was super exciting. And it was really nice, actually, because the 2 sessions that we had at the UN. One was on women's health, where I just sat and listened because I learned so much about women's health around the world. I'm always learning every day. And then in the afternoon, we were focusing on AI and the enablers for it. A number of us there agree that this is really an industrial revolution, especially with large language models and generative AI. The capability is a quantum leap. And when you make a large shift in capability, you need to think about your new target operating model. And Louise, we've done a forum together and come to that conclusion. This is really to try and mark and say, we need to change how we operate. And that's really a systemic question. This isn't just about dropping in little bits of AI all over the place. This is about saying, do we have the governance? Do we have the policy to enable these things to change for everyone's good, our health and care system?
Rachel, really want to get into the substance of your talk, but it's not often that every day people get to hear someone who's had the experience of addressing the United Nations. What anecdotes do you have? Like, what sort of protocols and logistics? How does it work?
Well, it's really interesting, actually, because one of the parallel sessions with the Clinton Foundation, and I actually worked with Chelsea Clinton 20 odd years ago.
Oh, cool.
She was working on the NHS. So there was the whole Clinton Foundation piece that was happening. There were people from the White House. There were people from the United Nations. There were all sorts of people there. And I think for me, the first step for us globally to embrace any technology is to talk the same language and share the same frameworks, same understanding. And so it was really about a lot of senior people listening to one another and creating a shared understanding. But yeah, I mean, it's super amazing to be there. And actually the first time I spent a night in New York, which is crazy. I've gone to the airport and I've had long layovers, but it was really interesting to be in New York with all of those people. Everyone was there, everyone from patients right the way through to senior policymakers, people that work globally. So it was a really nice mix. But yes, you kind of feel a bit, I don't know, a bit humble about some of these things because it is a really big opportunity. We've got to plant some seeds about the future and start some bigger conversations with people. So yeah, it was great.
I imagine when you're at the United Nations, the level of conversations and the diversity of those conversations and the people you meet must be at a whole other level.
Absolutely. I mean, particularly for the women's health bit, the piece that they had around women's health, there was just a phenomenal variety of people from around the globe. And I'm hoping that we get that with the AI conversation. I think it needs to be broadened. You're seeing patients, you're seeing clinicians, you're seeing all sorts of people from Africa, Asia, South America. It's important to have that breadth of debate.
So I looked at the actual program and I actually did stay up for your session and for the previous sessions with the digital health group. The number of different events, it was literally hundreds of side events. And so it was a really fascinating program. And I must admit, staying up at 5 a.m. for yours was the highlight of it.
Thank you. I kind of went away with cognitive indigestion because I just taking in everything I was hearing. There's so much I've still got to learn. And I'm glad that those discussions are being had on a global scale.
The whole idea of the UN General Assembly is to promote global collaboration, and the ECHA Alliance, which we are both ambassadors of, also seeks to do the same sort of thing. What can we do in Australia and in other countries to make sure we play a greater role in that global collaboration in healthcare? How do we get this global collaborative model working?
I think it's two-level. And actually, I've been doing some work with one of the state governments in Australia. And my view is there is the government level. I think every government needs to participate and collaborate. And I've got to say, my hope is the UK government does a bit more of that. So I think there's that policy piece and the national collaboration at the state level and so on. I think every individual and every layer of organization needs to create its international links. We all, as digital health professionals, need an international network. And actually, part of that is about the fact that we can pull on examples, we can pull on experts, we can support one another. We've got the International Patient Summary and other things where we're going to start collaborating. And that's a really good start for what we need to do. For me, I've always lent on international people. I remember bringing them into the boardroom when I was a CIO or getting their quotes from my business cases or whatever else. I know from my policy work that policy is a slow process. And perhaps we need to change how policy is made in some cases. But you can't really wait within health systems for your government to do this for you. right? And they're certainly not going to make those international links if you're going to look at other international sites that got the same EMR or international sites that got the same demographics of population. It's really down to you. So I think we need the informal networks, but also at that policy level, we do need to work together, because if we do things once globally well, where appropriate, we're standing on the shoulders of giants, right? And actually, we have seen a fragmentation of the supplier market because different countries have wanted different things, which has then led to unsustainable solutions where, a state in Australia is the only client of something that's across the rest of the globe, but it's had to be localized. That's costly and it's not necessarily efficient. So especially for Australia, I think those international networks are important, because you have so much in common with the UK and Europe, and we should work together more. I believe in networks. I believe that we need to do this at every level. And I'd love to see the digital health profession having some kind of global recognition or global currency, because there's something really healthy about people working in different countries and pollinating the ideas and their thinking.
The things we're dealing with too, Rachel, they're not so different, are they? You're lucky enough to get invited to the United Nations, or you're a government policy person or whoever, and you get invited to national meetings and international meetings. But often it's the people who are implementing things on the shop floor, these digital health professionals, as you said, who have to do this day in and day out, and they don't usually attend international events, and often they don't even get the opportunity to attend national meetings. What do you think we can do to improve the communication and collaboration at the almost like the shop floor level of digital health, not just at a policy level and an executive level?
So I think every digital health professional should have continued professional development, right? And that should include exposure to all of the environment around them. It's quite shocking, actually, that we don't really explain to our digital health professionals the health economics, the health system that they work in, the way other health systems work. I think about some of the people I've worked with. They're brought in and they just think, okay, I do cybersecurity, or I do, end use devices, and I just work in this little bubble. And we're not nurturing or supporting our individuals to understand their context, to be able to speak up and say, here's some things that I think would really work. We're not exposing them to the international debate around, say, standards or around global best practice. We have made some moves in the UK towards this with FedIP and so on. But I think they should have ring-fenced time like doctors and nurses have for continued development. And that really should be something that gives them far more context in terms of the role that they do. So we're not necessarily leveraging the best of our talent.
Yeah, and growing that. I think everyone listening to this is going to be quoting you now to their boss and going, look, Rachel Dunscombe said it's really important. I'm putting forth a budget request to attend this. Yeah. But it's a really good thing, because it's not just about getting, to meet other people. It's about the professional respect and the professional recognition, isn't it? That what you do is unique, important, and there are others that you can learn from around the world, and also contribute your own learnings to other people to take back and implement.
None of us can do this in isolation. This is big, complex, and we need everybody's brains on it. And yes, they can quote me. I used to be fairly bloody minded, to be honest, because there wasn't continued professional development. So I'd take leave if I needed to. I'd pay for my own travel and events if I needed to. I would challenge myself to learn something new, do something new, make networks, not because I want to be out and about or be on a plane, but because I wanted to make sure that I had that kind of 360 view and was thinking systemically. I really feel we need to do that. We've got such talented people in digital health, and I see so many of them that could be enabled to do so much more.
I have to agree with you. I mean, Louise and I first met in San Francisco, even though we're both from Australia. So that idea of actually going out of the country and meeting people and listening, there is something to be said for being in the same room, breaking bread, sharing a glass of wine, talking about your families and what the connotations are for them. I think the humanity in us requires that. So yeah, call out to all our colleagues that when you're looking at continuing professional development, overseas is a fun place to go. And hey, you can sometimes tie it in with a holiday. Tax department, I didn't say that, but anyone else, that's the way to do it.
So, Rachel, your address was on the topic of the importance of quality data in driving AI in healthcare. What were the key messages and takeaways you were hoping to leave people with? And what did you learn from others in that session?
Oh, I learned some really good pieces around quality checklists for AI from the Israeli health system. And I've read the research since. So that was super good for me. Again, you learn every day. So the piece for me was twofold. It was around the quality of data. Yeah. So within my EMR, the same concept, something like blood pressure or other observations would be recorded tens of times in different ways with different data fields. So you couldn't pull it together to actually get trending for AI or to train AI easily. So I was talking about my experience, some of the work that I've done actually looking at one of the countries in Europe and EMRs there and how disparate the same concept is within a health organization. Just a simple concept, right? And why we need to pull our data together. So again, CIOs across the globe are busy managing hundreds of systems. Even if they've got an EMR, there are hundreds of systems around it. And none of these have been engineered well. They've been engineered for a human to record, for a human to read later, maybe in a discharge letter or whatever else. That's where they came from back in the 90s. We need to move to the next generation where we're engineering data well for all uses. So for the citizen to use, for longitudinal records, for AI. So it's talking really about we need to get on the right page of data engineering. So that was the first point. The other points I was making were the fact that AI is an iceberg, right? We see all of this promise above the waterline, but what's actually underneath it is we're not creating the governance that we need. We're not creating the life cycle management because you need to manage this ongoing to make sure that it's performing well. We're not training people in what AI is and how they can leverage it. And the whole systemic piece, I've just been doing some work on lessons learned from where AI has been implemented. And what we're seeing is that people are just dropping something into a tiny bit of a process, but not considering how you could get the benefits of systemic redesign, right? So we've got this capability from AI. How do we reimagine what we do to get the total benefit? So everything under the iceberg, you just see this lovely, okay, it's going to cost me $200,000 for this AI. Isn't that great? Well, you haven't considered all of these things that you need to do that are going to cost you, but give you a lot more benefit. And it's a lot more likely to be successful. So I guess mine was probably a bit of a cautionary tale. Get your data right before AI. Get your governance and investment right. Take our time and do it methodically and put in things like risk and opportunity management. Get our boards ready. Then we've got a chance of making this really successful.
One of the key things with AI has always been the quality of data determines the quality of the AI. Do you want to comment on how you better improve data quality so that we can actually use good data sets for AI? Is that something that we need to focus on first before we get carried away with the generative AI examples we've seen around the world?
Absolutely. So yes, data before AI, get it right. I say AI is what it eats, right?
Oh, perfect.
Yeah, it is what it eats. Some really nice research coming out of Berlin at the moment around performance of AI on different quality data and different formats of data, which is going to measure some of that. We know it, but we need to quantify it. So some of the steps around data, the first one actually is let's start with the human clinicians. So the systems they have are not necessarily right for putting in data that can be used for multiple uses. Quite often they just put free-form data in, or indeed some are still on paper. We need to create systems that are right for the quality of data that can be used in AI. So that is really important. The second one is the usability of those systems and the explanation for the clinicians. Because one of my experiences was using data with data science teams. And in RED, people are saying we're having to put more data in. Why? You have to explain why. And you have to send them postcards back saying, thank you for putting this data in. You've now helped save this many lives or improve this many lives, right? There has to be a purpose. So the whole training, usability, and concession actually, as there is with any digital system, of some areas having to put more data in, but it benefiting other areas and putting the right resource in. So that whole consideration, the front end, the usability, the input, the human side of it. In terms of the sort of technicalities of the data, I think we're starting to get to a place where we are standardizing the data. And that is quite hard from a number of the systems we've got, be it vendor lock-in, be it a lack of APIs or interfaces. These systems weren't designed for taking data out for AI.
They're out for any purpose, really.
Right. For the patient, for anything. My view is we really have to help the vendors in the market. We can't just beat them over the head and say your product is no longer fit for purpose. We potentially need some incentives, give them a reasonable timeline of years to actually start moving towards good data. But we need to work with the market. And we also need to work with challenger players as well, because without a doubt, there will be some big player out there that will decide to create the EMR that's optimized for data and for patients. And on the technical side, I'll be shortly announcing some more partnerships, but it's really nice to see all the standards bodies together in the room saying, how do we complement one another? How do we stop doing things that overlap? How do we create a cohesive story and how-tos for healthcare systems so that they can get their data in order? So I think that work is really important. It is hard now, though. I've done the data wrangling with my teams and it's never perfect. It's always really difficult. So we've got a journey to go on. And for me, data is the new infrastructure of the healthcare system. So traditionally, it's been in your hospitals. It's been those lovely shiny glass and steel buildings that we built. In the future, we're trying to move people out of hospitals. And the infrastructure of the future is data. That is the virtual hospital walls. And when we build a lovely hospital, we have all these engineering standards. It's well engineered, form follows function. We've done a lot of planning to see how many people are going to walk around and where we optimally place stuff. We need to engineer our data that well so that it can be the virtual hospital walls. So, for me, I try and get boards and chief execs to actually visualize a new hospital and all the rigor that goes into it, and then data being a parallel for the future and what we need to do.
And how does that conversation go down? Like, how do you get it to resonate that what we're talking about with data standards and data infrastructure really is critical and you can't run healthcare without planning and attention to this detail? How do you make the impact on that message?
I think you've got to use metaphors and you've got to start with something they really know. So 2 things they know is about building hospitals traditionally, things like clinical risk. And you kind of say to them, you understand that's infrastructure. This is another set of infrastructure that you need to be able to leverage and manage. Drawing metaphors around building standards, engineering standards, form following function, and just take them on a journey saying, build a picture in your head of this being a virtual hospital that exists with the data powering it. One thing you find with boards is they either fear this topic because they think it's too complicated, or they're contemptful because this is all about IT and you have to take them away from that to get a bit curious when you're working with boards. Get them hands-on, maybe hands-on with a large language model that you've got some data in or have trained. Get them hands-on with something you've done. You can get them to navigate it and just ask questions. Where do you think this could be used? You've almost got to give them permission to be in this space because for a hell of a lot of boards out there and senior leaders, it seems like Star Trek technobabble. Louise, ePatient Dave. I mean, telling stories like his. I've been talking with him a lot and we've been sharing his journey with others of using large language models over disparate patient records he has, pulled together something cohesive. Now, is that clinically safe? Well, if we did it, because it's already disparate data, it may not be clinically relevant, but for him, it enables him to build a single picture and he can check his own record because he knows what should be in there. These sorts of things, citizens are doing this. We're not going to be able to stop the citizens. We've got to keep up. So really, for me, this isn't something to fear because if you're a board and you can manage clinical risk and you can manage building a hospital, you've got the skills to do this. You just need to build the paradigm in your head of what this is.
So we should be asking you board members whether, one, they watch Star Trek, B, whether they're nerds. I agree. I think that's a definite requirement. I'm quite happy. Yeah. If they say live long and prosper at the end of the conversation, we know we're going right. We have seen that dichotomy. Now, New South Wales Health made some announcements just a couple of days ago about a shift to virtual wards. And it's still relatively small scale, but again, it's a minister who's au fait with the value of technology. But the key thing here is, how do we get the community to demand this? Because boards are risk averse. Boards will do what they need to do to keep their organization safe and stable. But when you speak to my 30-year-old son, who's a doctor, he expects all this stuff to be available.
So I think we've got a coming storm here. The coming storm is the millennial doctors and nurses who are like, where is my, tech? The latest generation, not 1990s. You've got the citizens who are starting to demand their data and use this over it because they haven't got anything else. You've got big industry players who haven't traditionally played in healthcare, who've done amazing things in other industries, right? Who are now thinking about how they actually adopt and adapt that into healthcare. And we've also got health systems not being economically affordable, right? So it's a perfect storm in that sense. And what do we do here? Do we create kind of parallel organizations like a digital first healthcare organization that sits alongside your hospital? Is that what we do? Or do we try and disrupt from within? If you look at Finland, they have citizens' assemblies that are voted for 2 years that drive direction of healthcare. And actually, they're pretty digitized. Their data's pretty good there. Maybe we need to change the structure of how we actually deliver healthcare, but we also need to get a lot more agile. I remember having an argument with one of our regulators in the UK who said, give me a 10-year plan of all of the capital you're going to spend as a CIO. I said, oh, will do, but it'll be a work of fiction, right? Because we need to navigate this. We need to, in real time, say, here's a risk, here's an opportunity, here's a whatever, and change how we spend our money to deliver value. You can talk about some of the enablers you'll deliver, but you can't say exactly what you're going to deliver in 10 years. We need to be able to learn how to navigate dynamically because this is a really changing world. So I think we need really good leadership. If there's one thing we need in digital health, it's good leadership from everyone in an organization to enable digital health. But what you can't do is absolutely hard code everything you're going to do for years. When I had the Innovation Center back at Salford, I was very lucky that Sir David Dalton and Raj Jain, who were the chief execs sequentially, allowed that to be an investment center. So overall, it was to generate an ROI. But what it wasn't going to do was say exactly which projects were going to deliver what, when. And it was going to kill some projects, which were for learning, where we'd explored something and it wasn't possible. We stopped measuring the minutiae and saying that it still has to be delivered. We're not very good at saying that still doesn't make sense. There's something better we should be doing.
But being told that AI will revolutionize everything in the next decade or so. And just a warning here, I've been reading Ray Kurzweil's latest book, The Singularity is Nearer, which suggests that in the next decade or so, we're going to actually be hybrids, AI combined with human biology and cloud-based brain supplements. That seems a bit far-fetched. In the short to medium term, what should we be expecting from AI? Is it just going to improve our data or is it going to improve our quality of life?
I think that could go either way, right? And I think it's about how we lead through this generally in society. I've got some real issues with the way that some AI models are completely closed IP and we can't see how or what they're doing. So there's a lot of moral pieces we need to look at here. Very obviously, what AI can do for us immediately in health systems is things that aren't front and center with the patient. We can use it to automate. We can use it to provide oversight views for clinicians, pull out information from patient records potentially. We can use it to really build efficiency and improve the kind of experience for clinicians. We can also use it to go back. This is what I love about AI. You can use it to go back and say, what are our real problems here? Go to my data and tell me what problems I have in my population, what problems I have with my operating model. I had a really interesting philosophical debate with a good friend of mine, one of my AI buddies, Max Jones. He's one of the CIOs in the UK now, about whether we should have boards, agendas set based on what AI has found. Okay. So you send AI off to go and say, what are our performance issues? What are the issues in our population? What risks can you find? What opportunities can you find? Set me an agenda for a board. And I think that's quite interesting. There's an awful lot that we can do in that space because, frankly, we don't really have a good handle on our populations and what the sort of ticking time bombs are. So for me, AI, the clinical space, yes, we need to take more rigor around that. But in the corporate space, I think we could start changing how health systems are run.
Excellent.
But I'm not going to be a cyborg, although I am diabetic. So I have a continuous blood glucose monitor, which I'm grateful for when I need it. The whole cyborg bit, I'm not taken with that unless there's a good medical need, right?
Absolutely. I think maintaining the humanity, but using the AI to improve the quality of the life that humanity is key. And a lot of these books coming out of the West Coast United States tend to paint a picture that's a little dystopian.
It is. We'll see where we go. Well, Rachel, thank you so much. I know it's very early in the morning for you at home there. And thank you so much for making time. I didn't mention it before, but you are joining us on the 10th episode. This is our 10th anniversary episode. So thank you so much for joining us and regaling us with stories of the UN. And wonderful to have someone with your global experience, the people that you speak to and your own knowledge come onto the pod and share some wonderful anecdotes and stories with us around where you think AI might be going and what we need to be focusing on now. It's been great having you on the pod.
Well, thank you both and keep up the good work. It's a real privilege to be here. Thank you.
I'll just put in a last minute plug because the Digital Health Society has their upcoming meeting virtually. Will you be part of that, Rachel?
I think it might be 5th and 6th of November. It's the same time as our OpenEHR conference in Reading. So I will try and drop in, but I'll be catch up on the sessions for sure.
Excellent.
See, this is where AI, Rachel, you said you don't want to have the whole chip, but if we could have virtual Rachel, you could go to both events at once and contribute both at once.
Absolutely. Maybe that's the coming future.
I prefer the real virtual to the digital twin Rachel, so I'll stick with the real Rachel for the time being.
Great. Thanks again.
Thanks, everyone.
Take care. Bye.
Now it's time for an update from our correspondent, Kate McDonald from the Pulse IT News Desk. Welcome, Kate. How are you today?
Fantastic. We're very busy here at Pulse IT in the conference season, it seems to be in Australia. They all happen in October and November. We're looking forward to one conference on health information management, one on practice management, AI in healthcare, AI in community care, which is a new area. And there's Victorian Healthcare Week, which is always good. And then every year at the end of the year, there is a regular conference on successes and failure in telehealth, which we very much enjoy. Meanwhile, we've had a pretty big week in primary care innovation and technology this week. The RACGP released their Health of the Nation report last week. They made a few waves over the last couple of weeks with some critical findings about a third of GPs never using the My Health record and worrying figures in particular on the GP workforce. But the actual report is a bit rosier than expected. There's a whole chapter about innovation, and it was a big survey of over 3,000 GPs. And the big finding in the innovation area was that GPs had quite a positive view of innovation, defining it in the report as new ways of delivering care and communication. But they were worried that they weren't being kept informed with new developments in innovation. And we suggest they take out a subscription to Pulse IT and they'll learn all about it if they do that. From reading the report, we think GPs themselves have a bit of an overly rosy view of their positivity towards technology. We've been reporting on this area for a long time, and GPs aren't really known for adopting a lot of technology quickly. They think they do, though. 35% of GPs called themselves early adopters, and another 34% said they tended to adopt new innovations when people around them were doing so. But they also said 31% said they felt overwhelmed by the rate of change in the innovation sector, which is an interesting thing as well. Separately, they are very worried about the viability of general practice in Australia. We mentioned before the Commonwealth Fund and access to healthcare is a big problem in Australia, but the actual viability of practices is a big concern for GPs. They're going out of business, some of them. They're closing down practices, a surprise for a lot of people, I'm sure. It was interesting that this sentiment was so strong in the Health of the Nation report. At the same time, we had a really good story last week on doing digital health maturity assessments for general practices. And there is a real link that's been shown in the data to digital health maturity and practice viability. The more mature the practice is in terms of its technology, the more viable it is financially. Australia's primary health networks are now offering a new tool to practices to assess their maturity, and it gives them an action plan on how that they can make improvements. And this has been adapted for the aged care sector as well, for residential aged care. It's a really interesting work. The hospital sector has shown that digital maturity leads to better patient care. and patient outcomes, and a financially viable primary care sector will certainly do the same. We also covered that consultation paper on AI that you mentioned last episode, Louise. It seems to be quite a popular idea that healthcare be carved out from other industries when looking at regulating AI because healthcare is so important and so high risk. That seems to be a popular thing. We see that the UK is planning to set up a regulatory innovation office to speed up approvals and regulations for AI, and healthcare is very much at the top of the list. We polled our readers on whether they thought there should be a separate regulatory body specifically for AI in healthcare, and about 71% of our readers agree, which is pretty big. There were a few comments saying that there's too many regulation already. That comes as no surprise to anyone. And looking ahead, the Australian Digital Health Agency has released its own consultation document, this on the health information exchange that has got Australia's digital health industry very excited over the last couple of months. The document's pretty heavy going, I must say. It's all about architecture and infrastructure, but it does have a really deep dive into the first phase of the build of the HIE, which is being called the directory. And this is going to be the authentication and authorization framework that enables trusted exchange of health information. And it will also be one national access point for directory information, so clinicians can find out where information on their patient is held and how to access it. The Digital Health Agency is holding a webinar for industry and vendors in a couple of weeks on this, so we'll be watching that closely. And that brings us to an opinion piece that we published about a week and a half ago that proved incredibly popular, and that was about the HIE and how in future, when we build it, there are some strong arguments that commercial entities should be able to use the data that this HIE is going to hold. Now, anonymised data, obviously, and with the right consents in place. That set off quite a bit of a storm that we were all surprised about, that our readers are not keen on that idea, are not keen on commercial entities, whether it, software developers, big pharma, etc., have access to that data. 3/4 of our readers said no, they shouldn't have access to that data, even with the right consents. And one said not only no, but hell no. I like that one. We think it actually can be done. That with the right consents, third parties should be able to have access to the data and use the power of that data. But in Australia, when you consider we still don't have legislation for the secondary use of My Health record data after 12 years that the system's been in operation, we could be waiting a while to get access to the HIE data, that's for sure. So it's been a big week, as always.
Huge week. Some great variety of topics. Thanks for bringing them all to us, Kate. I find that fascinating. There's conversations I've been hearing here are looking at regulation of AI. I mean, everyone's talking about that, especially in healthcare. But looking at, is the right way to do it at the application layer, or is the right way to do it at the data level, at the LLM itself? And that seems to be people in one camp or the other. Here in America, they certainly don't want it to be at a state level. Imagine the amount of compliance. If California is different to Texas, different to Kansas, the idea that you would have to have different compliance for an application in its rollout in different states, it's completely unworkable. So, but then there are people who really think it should be at the application layer, but at least done at a national level. But I would think, we really should be talking about this internationally.
It is a very challenging area because until we fully understand the implications and how AI works, and to many of us, it's still a black box. So how do you regulate something you don't even know what's happening behind the scenes? So again, education around AI is critical. You need the healthcare industry to get much more engaged in understanding how this AI comes to the decisions it comes to and how we use it. But I think all the stories have been really interesting, Kate. I mean, I note my GP colleagues consider themselves to be very innovative, but I guess the GPs, they may be comparing themselves with their specialist colleagues, and compared to them, they're really innovative. Consultation papers on AI. My only concern is that we have a Royal Commission into AI and we spend the next 3 years publishing a 12-volume document on AI and where that leads us. Having gone through that in aged care, please don't do that to me again. And then finally, the HIE. The HIE really is an opportunity for us to get into second gear. Digital health has been running along in first gear. We haven't been able to fully leverage what it can do. HIE may be our opportunity with using FIRE to get us to the next stage. I think the most important thing you said out of all that, Kate, if you want to keep up to date, read Pulse. So get on board, read Pulse, listen to Pulse Pod, and you will be one of Australia's up-and-coming digital health experts and in a position to have a real opinion.
Well said, George.
George, absolutely. I agree with you entirely.
All right, well, that's a nice place to wrap up. Kate, thanks for bringing such a great variety of stories to us. And I love the data. And thanks everybody who's listening who actually completes Pulse IT's polls as well. It's really fascinating, the insights. And thanks for bringing them to us, Kate.
They're not overly scientific, I should say that, but they reflect the views of real experts in the sector.
The buzzword in healthcare is real-world evidence, and you provide real-world evidence.
Yep.
That's right. Yes, and very engaged lot. All right. Well, we'll speak to you in a fortnight, Kate.
Thank you.
Sounds like we'll have more things to report from conference season.
It's very exciting, sort of.
So, George, we have just wrapped up episode 10. We're in double digits.
Woohoo! Is it time for a party? You're in Vegas. Whatever happens there stays there. So we'll party when you get back.
Okay, yes, I have to be very careful what I report on from my time in Vegas, but no, it'll be good. And actually, because I am on the road, I should give full acknowledgement to my partner, Ryan, who has helped me diligently with the assembling and dismantling of my various pillow forts that I have had in the Airbnbs we've been staying in. He's done a great job helping me behind the scenes for the podcast.
Big thank you to Brian for that. I know he's been a staunch supporter of digital health in the background for many, many years.
That's true. He has. He just didn't know that podcast pillow forts would be part of his job description, but now it is. All right. So, George, I will be back with you in the studio in a couple of weeks. And yes, I will have completed my stint at the health conference in Vegas. So I will do my best to endeavour to have some good stories to tell and report back on some good conversations. And actually, someone who is presenting at health, I don't know whether I'll have a chance to speak to her. We've met before, but a lot has changed in that time. And that's Anne from 23andMe.
Excellent.
So she's going to be speaking because I'm sure she must be shopping it around. I mean, all the board members have resigned. They've been threatening with delisting because their stock price has plunged. It's almost a penny stock now. But anyway, it'll be interesting to see what she's got to say at the health conference.
Yep. I will be watching with great interest what's happening in health. I've got quite a few of my friends going over there. So I look forward to hearing how Louise has transformed the American healthcare system through her knowledge in Las Vegas. And tell them all to sign up for PulsePod.
Oh, definitely. Yes. I've got my Pulse t-shirts. I will be wandering around the expo and making everybody sign up. So yeah, I will look forward to regaling you with stories in a couple of weeks' time, George. Yeah, read us out from today.
Thank you for listening to Pulse, brought to you by Pulse IT News. Pulse is produced by Ivan Jurek of Octopod Productions. Thanks to Nigel Chartres, Emily Mara and Kate McDonald for contributing to today's episode, and for Ryan for helping us get those pillow fortresses built. Subscribe, follow and rate Pulse wherever you get your podcasts. You can subscribe to Pulse IT magazine at www.pulseit.news. Send your feedback and questions to pulsepod@pulseit.news. Thanks, everyone.